Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Nice to have you here. If you're watching us live, we come to you every Saturday at 9 a.m. Central Time, and we're on Facebook, LinkedIn, X, Kick, and YouTube, of course. And so if you're watching us live, be sure to add your questions and comments and let us know where you're coming from. If you're in the live, put it in the comments. Let us know where you're watching us from. Always fun to know where people are watching us from. This is your first time checking out the program, be sure to go to our website at uronurse.com. Best place to go to watch or to learn more about the show and see what's coming up and what's going on in our calendar. All sorts of great things to find out. And the best place to watch all of our 151 episodes that we have there. Every episode we've done is there. You just go there and find it. It'll be perfect. A lot of you like to listen in your car. I know I always listen to podcasts in my car. I got a long commute getting into work, so it's perfect. We're available about a half hour after the show goes off in an audio format on Apple Podcasts, Spotify, iHeart, Amazon Music, and YouTube Music. 5 different places. Just sign up and you'll get it every time sent to your box. So I got an interesting story to share with you today. So, I got that little box on UroNurse, as you can kind of see on the bottom, where there's a Ask UroNurse or Contact Us. Either one will get you to my email. And this is the email you're looking at up above that I received. I have no idea what that says. I'm not fluent in every language, but I saw Croati. I figured it must be Croatian. But you know what I am fluent in? Computers. So what I did is I put this into AI and asked it to translate it. And here's what I got. Hi, I'm writing from Croatia. Please, could you help me? I'm writing my thesis on erectile dysfunction. I work as a nurse myself, and I need information about nurse educators, what exactly they do, how they collaborate with doctors, etc. Thank you. So with the help of AI, I was able to respond back to him or her. And, it just shows the international appeal of our show. So it's kind of cool to have an AI to help translate. So today we're really talk about international. I have an international expert coming. Today's guest is Mai Majid, clinical neurophysiology specialist with a passion for solving diagnostic puzzles when symptoms don't add up. With over 19 years of experience across clinical research, hospital management, insurance, and urodynamics, Mai has carved out a unique path in neurology, neurourology, and pelvic neurophysiology. Her work alongside neurologists and urologists inspired her to launch a patient-centered private practice, focusing on collaborative, evidence-based care. Get ready for a fascinating conversation about the intersection of the nervous system, bladder health, and the art of decoding complex systems, especially chronic pelvic pain. And pain's the right word for it. Hey, welcome to the show, May.
Hello, Victor, and thank you for the really nice introduction. And I hope this presentation is up to the expectations of the people who decided to give us their time today.
I'm sure it will be. Now, just to give people an idea, so it's 9 a.m. here in America. What time is it in Cairo right now?
It's 5 p.m. Wow. And I hadn't had my lunch yet, yes.
Oh, man, you eat late.
Yes. We all do here in Egypt, yes.
Yeah. May and I were speaking a little before the show started about kind of the cultural differences between stuff that's done in America and that's done in Cairo. So it's going to be a neat thing to kind of get your not only your expertise in this field, but learning a little bit about what it's like to practice in a different part of the world. So I'm going to bring up your slides and take it away.
Thank you. Okay, a little about myself. I'm a doctor. I'm a clinical neurophysiology specialist. When I was in college, I was really interested in learning about how the bladder and how the pelvic nerves work. And I was impressed to know that it's just a little we know about how this complex network of nerves and muscles work. So I knew right away that I don't want to be a urologist. I'm not much into surgery. So I decided to go for the neurophysiology to dive deep into learning about how the brain and the muscles and nerves all are working together. So enough about me and my story, and let me share with you the story of one of my patients. Amr, my patient, is 35 years old. He's a male. He's having an average height. He's a handsome guy. He's an engineer. He started his private practice 5 years ago. And what was surprising for me is that I got this referral from a gastroenterologist, not from a urologist. The gastroenterologist was referring Amr for me to look if there is any problem in the pudendal nerve, and he recommended to do a pudendal nerve study. Amr was really frustrated with all the doctors, the urologist and the gastroenterologist, and even he was coming frustrated with me before even starting the therapy. He was always asking, will ever this pain goes away? So Amr is not a rare condition. It's actually more than 40 to 5% of the visits to the urology are men complaining about problems related to the prostate. And 15% are diagnosed with chronic prostatitis or prostatitis. Mostly you find these men in the age between 30 to 40, with the peak age between 35 to 45. And they have always sharing the same story, tried different kind of antibiotics, taking antibiotic courses, endless number of courses. Sometimes the symptoms improve a bit, but it's not less than 1 month that they have the symptoms back and the pain back. So this makes us asking ourselves, so where is the problem? Is it really a urological problem? Is it just prostatitis and we have done everything we can? The answer is no. A scheme was developed to look into the real cause for these patients, because 15% is like a huge percent, and 15, like we all know, it's just the recorded, and you can find the bigger, or the actual number is bigger than 15. So the U-Point scheme is looking for the main cause of the symptoms for chronic pain in men. U stands for urology problem as prostatitis. P stands for psychological problems, people with chronic stress or people with trauma, psychological trauma. And it can be organ specific. It's like it can be a problem in the kidneys or kidney malplacement or displacement. Sometimes it can be irritable bowel syndrome. We have to look for infection if it's UTI or prostatitis, and the tenderness in muscles. Recently, a new item was added to this list, is the sexual dysfunction. So is it just one of these causes is causing the chronic pelvic pain? The answer is no. It can be multifactorial. It can be 3 or 4 of these mentioned causes. So it's not one person's job to cure or deal with this patient. So if we got the explanation that it's muscle tenderness, what we look for this patient as a pelvic therapist, we look for the pelvic muscles. Of course, this is where our mind is targeted most of the time. We look for the pelvic floor muscles. We do the digital rectal examination and looking for tender points or trigger points. We have to look also for the piriformis muscle, where you find it in people who are sitting for long time, sitting during work, sitting during commuting. Even the sedentary lifestyle is that we all go home to just sit on the couch again. So it's just we're sitting probably most of the time. That makes this muscle really spastic and can cause pelvic pain. We also examine the abdominal muscles. Sometimes the tension or the tenderness is in the lower abdominal, the oblique abdominals. Also, we can find it in the glutei. So after examining all these places and all these muscles and find out the tender spot, the next question is, so now there is a tender spot. I find that I will manage to release this tenderness. Is it all? The answer is still no. Because you have to look at the urodynamic study. The urodynamic study, along with other causes, can bring this patient to their pain. So how can this be clarified? The urodynamic study can show us if the patient has an underactive detrusor. What mean by underactive detrusor? The detrusor muscle can, in some of these people, it's not contracting in a proper way. And when the detrusor muscle is not contracting in the proper way, the patient always have the feeling that he is not relieved after avoiding and he needs to spend more time straining or whatever. And this extra straining puts, again, pressure on the abdominal muscles, and you find tenderness in the abdominal muscles. This pain is referred to the pelvic pain, and it gets treated, as we mentioned, in the other way. He goes to the urologist, back to prescribing antibiotics, and the problem is totally elsewhere. You can find an overactive sphincter in the urodynamics. It's like there is no problem in the detrusor muscle, that the detrusor is contracting perfectly normal, but the muscle gets overactive and or spastic during voiding. These patients respond very well to techniques like biofeedback. It's just you can find patients improving over just 2 or 3 sessions, and the symptoms just go away. Sometimes it can be an overactive bladder. It's like an involuntary detrusor contractions, and with every contraction of this, the patient feels like a bit of burning or uneasiness sensation in the pelvic, and it gets translated into pelvic pain. So it's not only that we have to look to the tender points, but the urodynamics really help a big deal in deciding where to go with this patient. So the patient, as we mentioned, and as we all know, they tried endless numbers of antibiotic courses. So now come what we call as, or what papers are called, the complementary therapy. A lot of pelvic therapists find this word is like a bit unfair, because it's not complementary. It's an essential part of the therapy. It's equal to the urologist. It's equal to the gastroenterologist. It's very equal part that we're all playing here. So what's called complementary therapy involves trigger point release, that you work on the trigger points in any of these examined muscles that we mentioned earlier. You can learn the patient biofeedback techniques in how to breathe in proper way, how to relax the pelvic floor muscles during voiding. Is very impressive. You find really the dramatic responses to this, and patients love this because they get engaged in the treatment. They feel like they are part of getting better. It's on them as much as it's on you. So it's really a great add in treating these patients. With patients who are a bit reluctant for biofeedback or going through the exercises or doing the manual therapy, we try the neuromodulation. The neuromodulation devices are actually now, you find endless number of brands or machines that are offering many things, but it's mainly more or less the same technology. You work with different frequencies for pain treatment, for sometimes for relaxing the muscles, sometimes to inhibit the involuntary detrusor contraction. You just set the machine, and it's like a really simple work. Once you get the right diagnosis, you just set the machine and put the patient to the machine for 15 or 20 minute session. The patient takes 1 or 2 sessions per week. There is no consensus so far for how many sessions per week. It's just one, if it's 1 or 2 or 3, but usually it's 1 or 2 per week, and for like 6 to 12 weeks, sometimes less than 12 weeks, the patient can see very good results. Acupuncture is, I find it in many papers as a very good option for treatment of pelvic pain in these patients. In Egypt, we don't like it very much. We're not very fond of acupuncture. We found it like it's hocus pocus, but it actually works. I don't know about how it works in the United States, but I believe it actually works. It's really a science. So back to our patient, Amr. Amr had pelvic therapy sessions and biofeedback and neuromodulation. And in 4 weeks, he moved from having score 7 on the VAS score to score 2. And sometimes this score can get to 1 or 2, but it never goes away. For pelvic patients, pelvic pain patients, especially men, they are never back to 100% normal. It's never pain-free, but it's a bearable pain, like to score 1, 2, even 3 is really good with these patients. And they have like rebounds or flare-ups. Sometimes it's related to getting back to stressful event, like work event, life events, whatever. But the good thing for these patients is now they know the right way how to handle their pain again. They are coming for the pelvic therapist, and with just few number of sessions, they find great improvement. They don't have to go back to the urology and antibiotic, etc. So the studies shows that pelvic therapy is improving like 50 to 80% of the symptoms of these patients. Irrelevant of if you're having an infection with it or no, you're taking antibiotic and you have taken the antibiotics before, and for sure the organ symptoms is excluded by this time, because you usually see these patients after like 1 year. It's not less than 1 year from the first time they saw their urologist. So again, we cannot be unfair to the urologist because it's not a one-man job, and we cannot say that they are misdiagnosing or underdiagnosing. They are go by the book and try it once, 2, 3 times. When it all fails, they refer it to the pelvic therapy or the gastroenterology, and sometimes they refer it to the pain specialist. So I would like for anyone who knows a patient with pelvic pain, especially men, especially in this age criteria like 30s or 40s, just tell them that they can be sure that everything can goes to like normal again, and things are fixable. It's not just chronic prostatitis, and they don't have to live with this pain. Thank you.
Hey, it was really great. I just put down for if you want to ask any questions, go to the comment bar and put them in there. Just want to say that we got a few people that have said they're watching us and where people are coming from in here. We got Amy coming from New Mexico, Katie from San Diego, and Diane's from Seattle. We got quite a few more that are watching that didn't put it in, but that's okay.
No one is coming from Egypt, even my friends and my relatives.
We're our Egyptian folks. Maybe they're the ones that are watching, but they don't want to say.
Yes.
So, it was really fascinating. I got to ask you. You talked about biofeedback, and what exactly is your go-to for chronic pelvic pain? What's techniques is it for relaxing muscles, etc.?
Yes, actually, as I mentioned, there's more than one way to treat these patients. But for me, pelvic therapy is not one size fits all. You have to talk to the patient and say, we can do this, and we can do this, and we can do this, and find what he's more comfortable with. It's like I have some patients who are like very reluctant to do the exercises or the relaxation techniques like the abdominal breathing. They don't want to spend any time at home doing their homework. So you have to bring them to the clinic more often, do the trigger point release, and put them on the machine for the neurofeedback to improve the pain.
And you were mentioning that you use a machine. Is this something like one of those?
I have actually 3 machines. I have 3 machines. Yes.
Are these take-home machines or just something you do in your office?
No, it's I do them in my office. The home machine are really working and effective. We used to use them in Egypt, but that was like 15 years ago now. For many logistical reasons, it's very expensive to import these devices to Egypt, and the cheaper way is to come to the clinic.
Yeah.
Yes, actually, the device can cost you like 20 sessions at the clinic.
What was that again? How much would it cost?
If you're buying the device or you're having a 20 session at the clinic, it's equal.
Yeah, we had talked about the difference between the cost over in Egypt versus America, where everybody's pretty much has a healthcare plan that's paying for it. You said that that a lot of the patients are paying out of pocket for their healthcare. Is that right?
Yes. It's like 50% of the patients are paying out of their pockets. It's not cheap, but it's affordable for many of the patients.
Yeah. All right, we do have a
Yes.
question that came in. What kind of test should we order for chronic pelvic pain in men? So what tests do you
Yes.
like to see ahead of time?
Yes, that is really a good question. And the simple answer is it's not just one simple test, because you can exclude the urology because the patient definitely has gone to more than one urologist, and by the time you see the patient, you can exclude the gastroenterology or organ specific to that, like IBS or whatever. What you can do is here in Egypt, they ask for a pudendal nerve test. I'm not a fan of the test, although I do it in my clinic, but it's there is the myth of pudendal nerve entrapment, that it's causing the symptoms. It's less than 5% of the population that you'll find them with pudendal nerve entrapment. So, and this test is pretty expensive and really bothersome for the patient. So I find many doctors are referring their patient for pudendal nerve test, but I do not recommend it. What I recommend is that you take a full history, because again, the urologist, I'm not sure about the thing in the US, but the urologists are always looking for the surgery. So if you're just talking to me about your problems and where it's, they get bored with the patients. So listen to the patient. Tell them that you're not alone. This can be fixed, unlike what you have heard before. And for me, and also the paper saying it's like 60 to 80%. It depends on the pelvic therapy and finding where it really hurts and working on this specific things. Something else I do with the patients, if they are having more than one symptom, I start to categorize the symptoms and tell them the score, or like which symptoms is the more bothersome symptom. And we work on this first, then we come to this, because it can be different techniques for. So I'm not the one who's deciding.
Yeah.
But there is no single test in my opinion. Just really listen carefully, have a proper assessment, and this will lead you to the directions. It's not just a set path that you go through.
So we have an expression in America: if the only tool in your toolbox is a hammer, then everything looks like a nail.
Yes.
I think kind of what you're saying, that the treatment is, the urologist, if they can't fix it with the scalpel, they don't really care, because that's what they tend to do.
Yes, there is a very famous here pelvic therapist in Egypt. She's a doctor. She has a very crowded clinic. She works like 100 patients a day with many assistants but believe it or not, and she's very expensive, and it takes months to book your appointment there. But she has only one solution for all the patients. You go to the electromagnetic chair and you take 10 sessions on the electromagnetic chair. And this is all I can do. Yes.
And good success with this? We used to have that chair in America.
She's making good money. She's making good money. Yes. That chair works, but it can. It's not magic. Expensive. It cannot work with every patient, for sure.
Yeah, I used to do that.
Here in Egypt, it's expensive.
I was going to ask a question here. So what role do psychosocial factors like stress, anxiety, past trauma play in chronic pelvic pain syndrome in men? I find these patients seem to be like, you can almost tell who it is. They're very high-strung people, at least here in America. I'm not so sure how it is in Cairo, but
yes,
very high-strung.
No.
Personalities.
Yes. Exactly. They are very accomplished, very well out there. And like I mentioned about this guy, he's 35. He's coming from a decent background. And he started his private business 5 years ago. That was when the symptoms started. I couldn't tell him that frankly, but you can see the profile, because you don't want to, because he's going to resist it. It's as simple as this, but it's mostly, E-type personality. Yes. Amen.
Yeah. Do you have a most effective treatment strategy? You said multidisciplinary approaches for chronic pelvic pain, but then long term to prevent it from coming back. Any thoughts on that?
Yes, I usually work with the urologist because I like the effect of medications like the alpha blocker. It helps in relieving the symptoms. Sometimes they can help me with prescribing some like strong analgesics or some mood stabilizers or things that can put the patient into a state that helps you pave the way for the treatment you're gonna give for the patient.
Yeah.
So I mostly communicate with the doctors about giving them the prescription, and we work along the prescription. Because also it's not just the drug effect. I don't know about how it goes in America, but in Egypt, people are drug oriented. They believe so much in drugs. So if you tell them there is no medication, it's just me, they find it good for you.
Everybody wants a pill for everything, right?
Yes.
Yeah. And they'll shop around. I mean, we get patients coming into our office and they'll just say, "Oh, you know, my doctor always gives me this antibiotic and it goes away." Well, it's not, not a bacterial infection. You know, we've run the test. That does bring in another question I had. Are you guys using any of these DNA type cultures, urine cultures that look at DNA instead of the traditional culture where they just grew it out on a plate? Have you done that in Egypt, or is that?
No. We're doing the very old school urine culture, and mostly we don't do urine culture. It's just urine analysis. Just dip the stick, and okay, you have some bacterial infection. I mean, like if you do a random ESR test, you can have an elevated ESR. But does this mean that this is the thing that is causing your symptoms?
Right. Yeah. Yeah. Sometimes we've
and
had
there
some
goes
success
also
with that. We've had some success, but finding
it goes
organisms that we would have missed, but mostly not. And as you say, and it's just they want a chronic antibiotic, which is not the way to treat anything.
Yes, I mean, even if it's the organism, okay, treat the organism, but the pain, once the cycle of the pain goes to the nervous system, it's gonna stay there.
Yeah. Now, you had mentioned something in urodynamics that I didn't know about, and I mentioned I do a lot of urodynamics myself, is that some of these patients have low bladder tone, or what we call a hypotonic bladder. So it's not really squeezing as well, and that's causing some of these symptoms, you believe, right?
Yes. Symptoms. Patients with hypocontractile bladder are the most miserable patients on earth because they try everything, and unless you're putting them onto the urodynamic machine, because they fully empty their bladder, because they can empty their bladder. There is no residual urine. There is nothing, but you feel. When you find this, it's like he's never feeling relieved or he's done. For me, one of the machines I have, it works on the hypocontractile bladder. You work on a setting for the urinary retention. It gives a very high frequency current, electrical current, to the pelvic nerve, and they regain the bladder contractility. And the alpha blocker with this, it helps again with relieving the symptoms.
Yeah. So we have another question here. How do you approach patients who've seen multiple doctors without clear answers? Is that in our field? That's every patient that we see almost. You're the fifth or sixth urologist they've come in to see. What's your process for restoring trust and direction in their care? Which is the real
question. I don't know how you do it in the US, but here in Egypt, it's like when you go for it's not for you. If we have any female patients, when they go to the hairdresser, it's like, who did this for you? They must be yes. It's the same here in Egypt. Every time you go to another doctor, who told you so? I'm not from this school, actually. I try to explain the patients that they are doing the best they can. And unless you go to one or three doctors, you're not done. You have done the right thing, and you have to try it once and two and three times before coming to me. We are the last resort, not the first. Yeah. But so I always assure the patient that no one has done any damage to you. It was just the cycle.
I think one of the things that you offer that, they don't get at a physician's office is time. You'd mentioned you get a thorough history.
Yes.
Histories are like
Yes.
out.
Yes.
They don't even know sometimes how to, back when I started, we actually
you
used our
just
hands to palpate things. You could feel muscles were tense. Not so much anymore.
yes,
They just
you
kind
listen
of
to
order this test,
really?
order that test.
I have no tests to order. It's all in my hands. I have
That's
hands.
right. And I think that you
Yes.
can restore that confidence when somebody cares, or at least they seem like somebody's actually caring about their problem. That's a big step forward.
Yes.
Most of these
Yes.
people are just
Actually,
treated
yes.
with, they're brushed off. Here, get a culture.
This
We're going to try this drug. Oh, you're no better. Let's try this drug. Oh, you're no better. I'm going to send you off.
Yes, yes, and this makes a huge difference because the trust you build with the patients, you listen to them, you really empathize with them. This makes a huge difference.
Yeah. Yeah. Oh, that's
Yes.
good. So I'm looking to see if we have any other questions.
So I was suggesting something. I don't know if it works in the US, since you mentioned that there are private practices. I was thinking if someone has decided to open a clinic just for pelvic pain for men, and you just collect a group of doctors, a urologist, an enterologist, a psychiatrist, and a pelvic therapist, and a pain specialist, that would be really a great business. But I'm not sure. Here in Egypt, everyone wants to be the star, so you cannot collect them all together. I'm not sure about the culture in the US.
The physical therapists they practice on their own in America, and a lot of them, I should say a lot, several of them have gone into this specialty of pelvic floor pain. And
Yes.
if you can find somebody who's really good at it, we've had a lot of good results. The other ones that we have in America that do this are the chiropractors.
Yes. We have chiropractors in Egypt, but not so many.
Yeah, some have specialized in that. So, all right. So after 19 years in this field, you decide to start your own private practice. What inspired that decision, and how does your patient-centered approach look in action?
Yes, I've worked in many places with different backgrounds, different patients. It's every time I step in the place, I'm thinking like, okay, if I can have my own clinic, I set my own rules. I feel the patient feels comfortable. I feel the patient feeling he's welcomed and he's cared for. That was really what drove me into opening the private business also, although it was a big hassle. But every time I see the patients are feeling, I even have a coffee corner at the clinic. It's all about pampering them and feeling. It's not like a medical facility. You feel like you're going into like a cafe.
Yeah. And I think there's
Yes.
something in America, we kind of strive on trying to work for yourself and not have to work under the man, So I think it's nice that you get into being in your own
Yes.
business. We know it works
Really?
other places like that.
Yeah, really, for me, it was always about making the patients feel comfortable and feeling cared for and feeling that like they are home. They are not coming to the doctor. I'm not like the doctor's stiff personality. I want them to have fun.
We noticed that too, is a lot of patients are more comfortable when they're not speaking to the doctor. We call it doctor speak. Some patients don't think they can understand what the doctor is going to tell them, so they just shut off their brains and they don't know what, they're not listening.
Yes. Sometimes I sit with my patients before the session in the coffee corner, and we have a quick coffee, and they bring their friends, and we have all share coffee together before going to the examination room. It makes it all worth it, actually.
So, well, anyway, this has been fascinating. I really appreciate you joining us. I'm going to put a little plug in for next week's program.
Is penis shrinkage real, or just a myth whispered in locker rooms? In this episode of UroNurse, host Vic Senese dives into the age-old question of whether penises actually shrink with age, and if so, what the science says about it. With over 40 years in urology, Vic explores clinical studies, patient anecdotes, and the biological factors that can lead to changes in penile length and function over time. From lifestyle habits and vascular health to hormone levels and post-prostate cancer treatment outcomes, this episode offers a comprehensive look at the causes and what can be done to manage or even prevent shrinkage. Join us on June 28th at 9 a.m. Central Time to learn more.
So yeah, I'll be speaking next week on penis shrinkage. Is it real or is it not?
This is really a fascinating and capturing ad. I would love to watch it, and I'm sure every man out there and every woman would love to watch this because, okay, so I have something.
We're going to deal with some of the
yes.
some of the causes. Is it real? Is it not? There's a lot of, I think
It's
one of the
really,
big, I don't know how it is in your area, but one of the big problems we have in America is the porn industry. Gives a lot of guys artificial
it's everywhere.
knowledge
It's
of
everywhere.
what they think. Yeah, what they think a normal penis size is. Let's see. We did get some more. Thank you. Very informative.
Believe it or not. Yes, many of my male patients, they are always asking me, okay, you see a lot of male patients. Is this size normal for you? You got this question a lot.
Yep.
Yes,
I don't know what it is about men. It's, they always got to get the ruler out to be sure they're normal. And
yes, they need to be reassured all the time. Yes,
all the
even
time.
the patients, they are not reluctant to ask.
And we got another thank you. So people loved it. You did great.
Thank you. Rick.
All righty. So with that, we're going to wrap up the show. Be sure to join us next week to learn more about that penis.
Sure. I'm excited. Yes.
Does size really matter? I don't know. Maybe we'll get into a good conversation on that, but we'll see you next week on UroNurse.